Good afternoon. I want to like the case report on bilateral simultaneous central retinal vein occlusion in young patients. CRVO occurring commonly simultaneously both eye is a rare condition. Systemic vascular disease such as hypertension, diabetes are common risk factor for the development of CRVO that we already know. However, when a patient less than 50 years of age has bilateral and simultaneous CRVO, a hyperviscosity syndrome or inflammatory condition is also suspected. Retinal vascular disease occurs infrequently in young patients, and more than 90% of the cases occurs in people older than age of 50 years. Overall, only 10% of all CRVO patients are younger than 40 years of age. So the risk factors are associated with hyperviscosity syndrome due to hypercystinemia, malignant hypertension, chronic kidney disease, leukemia, multiple myeloma, and Waldenstrom macroglobulinemia. A 38-year-old male patient arrived in the retina clinic of Tejas Eye Hospital in the month of June 2021. The patient was having chief complaint of diminution of vision in both eye, right more than left, since 1 month. But actually the vision was same in the both eye. It was 460 on Snellen's chart, not improved with pinhole. Intraocular pressure of right eye was 11 mmHg and left eye was 12 mmHg. Anterior segment examination including the pupillary reaction was normal. The patient was having history of myocardial infarction 5 months ago and was treated with coronary angioplasty. The patient was also having diabetes and hypertension since 2 years. This is the fundus photograph. It shows simultaneous bilateral CRVO. This is the OCT of both the eyes, with around 450 thickness in both the eyes. The patient was investigated for CBC, ASR, RBS, lipid profile, urea, creatinine, homocysteine, and coagulation profile. The patient's homocysteine level was 55 micromoles per liter. The rest all reports were normal. The patient was started on folic acid, pyridoxine, and cyanocobalamin combination tablets and was advised intravitreal injection of bevacizumab after cardiologist clearance. Patient was not willing for ranibizumab injection due to financial issues. This is the cardiologist reports. After 1 month, the OD is showing resolving CRVO with note that there is significant disc pallor. OS is also resolving. So patient was advised the second dose of bevacizumab in both the eyes. And after the 2 doses, right eye CME was resolved, but left eye still is having CME. But the right eye IOP was 25 mm of mercury, so he was started on brimonidine plus timolol combination eye drops by glaucoma specialist. Right eye BCVA was 460, no improvement with pinhole. Left eye was 636 without improvement. So still the left eye CME was not resolved after the 3rd injection. So the patient was advised for left eye 2 mg IVTA as patient was phakic. Ozodase option was given but patient refused due to financial constraints. This is the follow-up homocysteine level which was back to 20. So patient was simultaneously followed up regularly with cardiologist for control of systemic disease. After IVTA dose, left eye CME was not resolved and advised second dose of IVTA. And the repeat serum homocysteine, as we see, it is 15 micromole per liter. But patient's second dose is still due and patient has lost follow-up as of now. There are reports strongly indicating that hyperhomocysteinemia is an independent risk factor for CRVO. Homocysteine has been found to be associated with patients with a higher risk of thrombosis. There are various mechanisms which includes endothelial dysfunction due to hyperhomocysteinemia. Also include decreased bioavailability of nitric oxide, altered expression of various thrombotic factors, mitogenic effects on smooth muscle cell, and expression of acute stress-related genes. Keeping with other thrombophilic condition, hyperhomocysteinemia is a synergistic with other hereditary and acquired prothrombic disorders. Exposure of vascular smooth muscle cells in hyperhomocysteinemia can lead to upregulation of inflammatory response, which characterize early atherogenesis and may in part account for the adverse effect of high homocysteine. So conclusion is retinal vascular occlusion in young should be investigated throughout for embolic source and any disease causing thrombophilia as well as local ocular conditions. It is an established risk factor for hyperviscosity in young patient which leads to ocular as well as cardiovascular morbidities. Physician must be involved in comprehensive treatment of systemic disease. These are my references. There is no financial